Thank you very much for this very interesting overview. I would like now to ask all the speakers to come to the stage for a discussion. Are there any questions from the audience? In case not, I would like to start with a question to Hedi Rishak. Hedi, you mentioned a very important point for all radiologists. You mentioned that it might be that we need only 2 sequences in our protocol. I think this is a very important statement because we have to reduce the examination time. We have to make the examination more easy, that more patients have access to the examination. So do you do at your institution only T2-weighted imaging and diffusion-weighted imaging? And the second question is, what about the B-value of the diffusion-weighted imaging? It might be critical. What is your advice here?
For me, for you?
For me. We should both answer. We are both going to answer that. I do believe that for the routine clinical studies, you actually don't need contrast. I know that we can all show anecdotal cases where contrast really helped, but there are so few between. And when you look at the time it takes, the UK study on cost effectiveness, really looking at the cost and how much the difference that there is when you use contrast, I just don't think you can justify the use of contrast for the routine studies. I know it is very different from many practices, but you know, we used to do spectroscopy routinely and we no longer do spectroscopy. I think we just evolve as the knowledge evolves, and we just have to change. Regarding the B-value, you know very well that the higher B-values have shown, especially the 2001 and the 15, and there are a number of recent studies how the higher B-value really further helps. You can really use B-value, I believe, above 800 or 1,000 if you use 3T. So it's going to be limited by the equipment that you have. I think probably because a diffusion-weighted image really doesn't take any time, and there is no contrast involved. Probably we should, for the routine, go to a little higher B-value, but we have to consider that so many people are doing MRI on 1.5 Tesla. So I think it's just, we really need to discuss what is clinically routine, clinically relevant protocol, as opposed to research protocol.
Thank you. Just to add something and ask a question to Eddie. From this point of view, just exposed, that means that you have, you may need 2 kinds of protocol, as suggested by the group of Nijmegen. You may need a detection protocol and a staging protocol. For highly selected patients, we have aggressive large volume tumors on the first step. So, as part of a detection protocol, I think that more and more often we definitely think that DC should be dropped. DC should be dropped. It's confusing sometimes. It doesn't add, and in a staging, in a detection protocol, we also now use the examination without the rectal coil, which Eddie didn't say, but at 3T, it's probably possible in this routine protocol, and even at 1.5, if you take your precautions, if you prepare the rectum properly, if you add some excitations, and if you use a multi-element pelvic coil, you can. But you can do a good detection with T2 and diffusion. Now, B-values is no more a concern, I think, because since the paper from the group at Nijmegen, you can use computed B-values, at least with the Siemens equipment, and you can use without a euro, and without a second, it's totally free. You can have a computed B14 and even B1600 B-value. So And for some patients, I would suggest that for staging protocol, for including patients in focal therapy or any kind of treatment which really is important, I would recommend a staging protocol with a rectal coil, and why not a 3 Tesla magnet? That's.
I pose a question to Professor Schroeder. In your opinion, when MRI is completely normal for a patient, active surveillance for a patient, do you perform biopsy or not? What is your degree of confidence in MRI when it is completely normal?
Very good. That's for you to understand. The question is that when you have totally normal MRI, do you feel that if the negative predictive value is high, that would you still recommend biopsy?
I think this is a subject of research at the moment, and it should remain so. I was very impressed by your optimistic view on no one who is getting active surveillance gets it without an MRI, and in our setting this is not the case because of capacity problems, because of the capability of the radiologists, because of the learning curves that is evolved, the different machines that are available. So I think there's a way to go, and the top priority in my view is to establish all these open questions and to work on them. And the radiologists should have a key role in this, and we are waiting for this. We urgently need the developments that I am trying to schedule with a few words. Now, at this moment, we have a study going in Rotterdam, which is using the technique you described, the dynamic fusion technique, and we are doing 12 core biopsies on everyone, and then we do an MRI-guided biopsy, blinded, so a different person gets in the same session the MRI information. And I think this is one of the ways to address it, which is it's blinded, but it's just falling short of a randomized trial that I think would be what the top priority, that the top information we need could be created.
So I can maybe revise, but just, so maybe I should revise the active surveillance. I can tell you in New York, you would not be put, not only Memorial, and in Toronto, you would not be placed on active surveillance without an MRI. It will catch up. And you know, the question you ask, we're trying to answer that question, and because what happens in the patient flow, patient comes to our urologist already with a biopsy. And today's standard is before putting them on active surveillance, we extensively rebiopsy. And the question is, can you obviate the second rebiopsy because of MRI? We think so, but we don't have the data yet.
I have something to say. There's something to say about the utility of MRI. In patient potentially included in active surveillance. There's really it's not fun to include a patient in active surveillance protocol if the MRI is done after the biopsy. You have so many artifacts that it's not worth to do it. If you want to do it, you start by an MRI. If you want to still perform biopsy on everybody, okay. But to assess the true negative predictive value of MRI, you need to do it before biopsy. Would you agree with that? Okay.
Okay, please. Go.
Thank you. On this. New York is not the rest of the world. Okay? And very clearly, San Francisco is very different from New York, because if you see what happens in the region of San Francisco, that in the low-risk group, active surveillance is not even considered. I mean, the world is so much at variance, and I think what I said, what we need, is so urgent that you should insist, and your tendency should be to get the world to evaluate this better and to convince us as clinicians to do it.
Okay.
Thank you. New York isn't the UK either, and NICE just published in January a 468-page heavyweight document on revision and prostate cancer, and we recommended for active surveillance, every man who has biopsy-proven prostate cancer who's been submitted after discussion to active surveillance is having an MRI at 4 to 6 months to avoid the post-biopsy hemorrhage problems. So that's going to be a nice, pretty much informs what will happen for the whole of the UK, which is about 30 million men. So we should have some data from that. That's the first thing. And the second thing, I just wanted to say that the ESUR prostate subcommittee is in the process of rewriting PIRADS. PIRADS 2 is on the way, and I wouldn't be making many secrets if I said that we're looking hard at TZ and DCE.
No, it's good. So we'll add UK to New York, and now we are the whole world. And Toronto, Canada is there also. So keep going.
Excuse me, I have a question about the contrast enhancement. Does it have any negative predictive value? In other words, like you see something in the transition zone on the T2 or on the DWI, and it does not enhance at all. Have you seen a cancer where it would be suspicious on the T2 and on the DWI and the transition zone and does not enhance? We're talking about when it's not enhancing rather than enhancing. Because I had a case, I have few cases.
We actually published those data for the radiation okay, the bottom line, if it doesn't enhance, fine. And also we need to learn from breast cancer community as we talk about PIRADS, and I know you're going to at the ISMRM hopefully get the second edition. In breast cancer, when you have an abnormality on any given modality, it means you need to biopsy. So that's when, now that they are working on the second edition of PIRADS, it's really, if you definitely see a lesion on diffusion-weighted image, you need to biopsy regardless what the other images show. But your question has been answered in the literature, and there are a number of cases where actually diffusion-weighted image is superior to findings on contrast.
And the second question is about the diffusion. Would you only look at the ADC? Have you seen, you have cases where the diffusion, the DWI is not bright and the ADC is dark, or you have to have matching signal?
Okay. Yeah, if I understand well, your question is, you mean it's brighter, it's bright on the trace images and it's not really dark on ADC?
No, the other way around. Like when it's dark.
Way. So it's dark on ADC, is not bright on high B value, meaning higher B value. This is considered as a score 4 at the moment, but it's been based, most of these score 4 have been based on the evaluation with a B value not higher than 800. But I think that should be evaluated again, because what's this dark on ADC and ISO at B2000, it's not really very suspicious. That's what I think. But again, I'm careful. And this is what we're going to do in the forthcoming weeks, because we have a meeting shortly to decide. But I think that the trace images, according to me, maybe Heidi will not agree with me, but I think the trace images at high B value are really what triggers the reading of the rest of the examination. Any bright focus should be considered as suspicious until you can prove the contrary. When it is dark, or globally dark on B2000, forget it. Well, it's a bit, okay, but it's just, okay.
I'd just like very much to express a couple of limitations that we see at the moment and that would prevent us to use the MRI in the way it is recommended. The paper by Hafner was cited repeatedly by both of you. It has identified 66 cases that were considered to be non-significant, no biopsy. But the routine biopsy found 13 aggressive cases in these 66. Now, that is confirmed in the big study reported by Siddiqui 2013 in the JNCI of the 536 case study, MRI study conducted at the National Cancer Institute. his conclusion on similar findings is that at the moment, the recommendation should be to do the 12 core biopsies and the MRI biopsy because of missing too many aggressive cancers in the low-risk group of the MRI biopsy. Would you comment on that?
I am sorry if I wasn't clear on active surveillance. We never said that we replace the biopsy. We do MRI in active surveillance group because we know, and it was published, that actually biopsy can miss the lesions. So if on active surveillance you find another lesion, then we now know if we have patient goes on active surveillance based on the clinical assessment, based on the clinical parameters that you showed, PSA, cores, and so on, and based on biopsy that's already done. Before signing on active surveillance, a patient has an MRI, and the role of MRI is dual. One is to see, is there any lesion that was missed on biopsy? And then that lesion is rebiopsied. And the second one is a baseline for the future studies. So we don't replace biopsy. It's a check, it's a safety check.
Unfortunately, now the time is over. Is there only a quick question at the end? Please, go ahead.
Do we have any data supporting that contrast is important for staging?
He wants to know if contrast is important for staging.
Yeah. I think so. Yes, yes. Well, when you have very good diffusion, it's important at the base of the prostate. At the base of the prostate, if you want to improve your accuracy in early detection of seminal vesicle invasion, you should use DCE unless you have a very good eye on diffusion. So, but I think it's still too early to say that you can drop DCE for staging purposes at the base of the prostate. But
the data are lacking.
Okay.
So I'm very sorry, but now the time is over. I think we have to close. The people have to go to other sessions. I thank very much all the speakers for the excellent presentation and you for your attendance.